This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
All patients with COPD should always be prescribed a short-acting beta agonist. And the reason for that is when they get an exacerbation at home, that's the first line of treatment for them. So if they're feeling a flare-up of their symptoms, shortness of breath or increasing cough, that's the first thing to do for them. So patients with COPD will be one of the cohorts with inhalers that will regularly have salbutamol prescribed, because that's no longer the case in other areas of medicine particularly. But within COPD, that is something a patient should always have. So regular salbutamol on their prescription.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm continuing my conversation with Dr. Shane McKeogh, lead author of the Irish College of GPs COPD GPU, which was published in October 2025. This is part 2, and if you haven't had a chance to listen to part 1 yet, please pause here, check out part 1, which is also available now, and then revisit this episode to pick up the conversation. Topics covered today include pharmacological interventions in COPD based on breathlessness and exacerbation assessment, an approach to augmenting therapy for symptomatic patients with established COPD, the role of eosinophils in management, and the evolution of care in Ireland via HSE integrated care hubs and the CDM programme. As usual, I'll include chapter markers and links in the show notes. Shane, we ended our last episode with an overview of non-pharmacological interventions in COPD, and could you please begin today by giving listeners a structured approach to the pharmacological management?
I could, and I think this is the area where many GPs and doctors generally will find this area intimidating, or traditionally have found it intimidating. And what I'd like to do is, as best I can, just try and simplify that. Now, in this conversation, again, I'm just trying to get concepts across. I will be referencing algorithms which really are worth looking at in the GPU. So, in terms of suggestions to my colleagues, I would consider downloading this onto your desktop, or recognize that you can get it at any time by logging into the college website. On the header of the page, it says GPUs. Go to COPD within that, and you can bring this up in seconds. So if you're remembering, this podcast down the road and you're thinking, what did that fella say? You can find it at any point, really accessible for members, and it's designed to be really useful in practice.
And the link again is in the show notes, and this visual piece is on page 8.
Fantastic. So just to talk about inhalers for a second, there are lots and lots of inhalers on the market. We know this. And I just want to try and break down and approach this from the GP perspective. So there are two types of inhalers that are worth conceptually considering. Ones that have inhaled corticosteroids and ones that have bronchodilators. And that's really the two main levers for usage within COPD, okay? Bronchodilators themselves have two subsets. So beta-2 agonists and muscarinic antagonists. Now, I can see people's eyes glazing over where they're remembering pathophysiology and that in medical school and at different times. The actual pathophysiology is listed in the general practice update, but just as an aid to memoir, really, you just need to consider them both as bronchodilators, okay? And people often use the acronyms for beta agonists of LABA, which is long-acting beta agonist, and LAMA, which is long-acting muscarinic antagonist. But essentially, LABAs and LAMAs are both bronchodilators, and that's really the main point to remember. So a LABA is a bronchodilator, a LAMA is a bronchodilator, and that's what helps with breathlessness, right? So that's the key piece on that bit. In terms of the steroid piece, inhaled corticosteroids really help for some elements of people with COPD, but probably in a change from where things used to be years ago. Lots of people with COPD do not require inhaled corticosteroids, where maybe 20 years ago that would have been a first-line treatment. It's no longer that way in that regard. So just that's the concepts of the two levers of treatment. And just to tie that back to that group A, B or E. So we've got our patient now who we've newly diagnosed with COPD because we clinically think they might have it and our spirometry has confirmed it. We've now asked our two questions around breathlessness and around exacerbations, and we've now placed them neatly into either a group A, B or E box. And the algorithm on the page in the GPU will tell you, based on group A, B, or E, which inhaler type should we be choosing. So if they're group A, which is somebody who's not having exacerbations and is not too breathless, we will be placing them on any bronchodilator, actually, most typically a LAMA. If there's somebody who's group B, so they're not having many exacerbations, but they are fairly breathless, we will generally place them on a dual LABA and LAMA together. And if there's somebody who is group E, which again is having any level of exacerbation, we're going to put them straight onto a combination of LABA and LAMA. Now, that's the concept behind how we approach it. And having that relatively clear is a useful way to then go, well, yes, but what inhalers will we actually use, which we'll come on to in a minute. But that's actually how we approach an initial diagnosis.
Yeah, that's really clear. And as you said, page 8 will give you the visual diagram of that. But even as a visual diagram, it's so much easier, as I said, than the ABCD because it simplifies it. Right, so that's, as you said, Shane, that's the conceptual approach to how we're going to go about pharmacological therapy.
Yeah.
And I know in many GP surgeries, there's the almost famous poster of all of the inhalers in a big long list. It's actually exceptionally useful and has, the visual picture of each different device type under each category. Is that still available?
It is, and actually, as a useful clinical nugget, I would encourage GPs listening to this to contact COPD Support Ireland, which is the support group for COPD, who will send you free of charge as many hard copies of that poster that you like. So in my practice, we have that poster on the back of each of the cupboards in our consultation rooms where we can check if a patient's in with us and have a quick look at it. And you can also download it as a soft copy if you prefer that on your desktop. But just in terms of what the poster, why I find it so useful is because it lists all the inhalers down for COPD, but it also lists them by class. So one of the problems with inhalers is they can be confusing because you have trade names and you have the actual constituent medicines, which are obviously very hard to keep a handle on. But the third column on that poster is really helpful because it lists all of the LABAs together, it lists all of the LAMAs together, and it lists all of the inhalers that are combined LABA plus LAMA. So you can see at a glance, if you have a patient coming into you and they're on an inhaler and you can't remember off the top of your head which class of medicine is in that, you can have a quick look at that poster and in seconds know, okay, this person's coming into me now. I can see they're on a dual LABA plus LAMA. And that allows you to start from a clear point in your head about where you might go next if you wanted to make a change. So that's why I find that poster so useful, and it's freely available, as I said, for free by contacting COPD Support Ireland. Okay,
and I'll include a link again to that in the show notes. Before we get on to the actual specifics of this patient's going to get a LABA or a combination or with or without a steroid, I have received maybe some advice previously around taking a look at that poster and the options available and just trying to simplify to the greatest extent possible for yourself around not trying to remember all of the devices and all of the brands and all of the options, but maybe having a couple from each in your armamentarium where you have a confidence and a fluency around not just the medications, but also how the devices work and maybe to keep them in your drawer. Is that a good strategy?
It can be, and some people like doing that, and it's a completely reasonable thing to do. I think it is worth, let's say now we've thought, we already know this is a newly diagnosed patient who's group A, B or E. So we've already figured out if they're group E, for example, I want to put them onto an inhaler device that is a combination of LABA and LAMA. And the next question becomes, okay, but which actual one am I going to use? So the GPU really helps in that regard on page 13. So it lists all of the devices for COPD and it lists each device that is available in each of those categories. So the LABA category, the LAMA category, the combination of both, which is LABA and LAMA, or in some instances then what's called triple therapy, which is LABA, LAMA and inhaled corticosteroid. So that's really nicely laid out by the Medicines Management Program for the HSE on page 13. And certainly it's something that you would need to refer to at the time just to jog your mind going, what is the name of that inhaler that's in that particular area? Now, conceivably, a GP can place a patient on any of the inhalers that meet the actual classes that are indicated here. So if it's group E, any combination of LABA and LAMA doesn't make a difference, will actually help the patient, assuming the patient can use it. But how I tend to approach it in a practical perspective is I often think to aid adherence in patients, the easier we make it for them, the more likely they will be to take it appropriately. So generally patients will prefer something that is once a day, like in any tablet that we might prescribe or in any medicine we might prescribe. So that can be a useful way to look at it. And again, that page 13 lists how often the patient needs to use it. Is it once a day, twice a day, or whatnot? And the other thing to consider is over time, you may want to change up treatment. So if somebody, let's say, begins on a LAMA treatment and you're seeing them back down the road and they're still getting a lot of symptoms of, say, breathlessness, you might be adding in a LABA to that. So it can be useful to think ahead, a bit like if we're using antihypertensives in a patient and you're thinking they might need to have additional agents down the road and we use combinations. The same principle applies to inhalers. So it can be useful to look at which devices are available in all of the different formats. So for example, it's available in a LAMA, it's available in a combination of LABA plus LAMA, or it's available as triple therapy of LABA plus LAMA plus ICS. That can be a useful way forward. It doesn't, conceivably, as I said, GPs can prescribe any of these. And if they have more experience in one or the other, that's fine too. But I find that a useful way to approach the question. And if you look at page 13, it'll break down those two decision-making strategies, I would suppose, I would think would be a good way to put it, and allow you to maybe choose inhalers on the back of that.
So that's our initial pharmacological approach to therapy, which was link 2 on the general practice update. And now we're going to look at the next link, which is an algorithm for the follow-up pharmacological treatment of this patient. And that is on page 9 of the general practice update. So we've diagnosed, we've commenced, and now they're back, potentially if they have a medical card as part of a CDM or otherwise. So what's our next step?
Okay, what I would say about this is I tend to approach this is going to be the lion's share as a GP of patients that you meet with COPD. So it'll be somebody who'll have been diagnosed at some point in the past, maybe by you, maybe by the hospitals, and they're coming in to see you. Ideally, if they have a medical card on a 6-monthly basis, and this is really how to approach review of somebody with COPD. The good news here is that it's simpler than we think. Okay, so again, there were 2 key questions we're interested in asking. One is, how breathless are you? And we define that on the MMRC scale again, 0 to 4. And the second is, how many exacerbations have you been having? None? Or are you coming into, again, this moderate exacerbation if you're seeing a GP, or out of hours when your local cooperative? That's what's called a moderate exacerbation. Or a severe one is going into hospital, okay, to either the emergency department or that. So it's the exact same questions that you ask when you have somebody newly diagnosed as you ask if somebody's coming back into you for review. And they're the 2 key questions to ascertain, is this person well managed, or actually do I need to do something different? I would say, so notably here, you will note that there's nothing about spirometry. It's not required in this context. For the review of somebody, it's based on their history to establish those 2 questions. If the answer to those 2 questions, I'm not breathless for argument's sake, and I'm not having exacerbations, then you're not going to change any management because that person is really well managed. You might look to optimize their vaccinations for argument's sake and help prevent, but you don't need to make any fundamental changes. And that's obvious, but just to say that, okay? So going back to our questions then, how breathless are you and how many exacerbations you're having? If the person answers yes to exacerbations on this, we have a useful algorithm that you asked me there on page 9 on the GPU to let you establish what to do next. So the first thing I would say with anybody who's coming in with symptom or for a COPD review is to always check their inhaler technique. So if they are getting exacerbations or are breathless or both, and we might think, oh gosh, I need to up-titrate medicine, we want to check first that we're not making a faulty assumption, which is that they're using their inhaler correctly. So I would say always tell patients to bring your inhalers to your COPD review, just like we tell people to bring their glasses to their driving license examination. So I have all of our administrators always just told them to do that and get them to just use it in front of you to check that they are in fact using it in a reasonably effective way. That's probably one of the most important things to do at each review of somebody with COPD. Assuming the person is using it well, and you feel therefore that they are having problems, refer to the algorithm on page 9, as I said, and it breaks it down into, is this person having exacerbations or is this person having breathlessness? If the person has both, the exacerbation piece is the most important piece to go on to. So you will see from the algorithm on that, if the person is having exacerbations, you can identify in the algorithm, well, what is their current inhaler makeup? Is it a LAMA on its own, or is it a combination of LABA and LAMA? And it will tell you what to do next on that algorithm. So you will either step up to the next level, which is quite clear, or if you've already got the person on maximum treatment, that's when you consider respiratory advice classically through the integrated care hubs, which again available through HealthLink, or if not available, then to respiratory outpatients. If the person is not getting exacerbations but is breathless, you would again step up in treatment. And the step up in treatment is relatively straightforward. Generally speaking, if somebody is on a single, let's say LAMA, and they are getting no exacerbations but are breathless, we will add in a combination of LABA and LAMA. So it's not that tricky to do. Similarly, if they're getting a lot of exacerbations, same general principle to add to become both LABA and LAMA. And occasionally it can be worth adding a steroid in based on a couple of other points, which we'll maybe talk about in a minute.
And as part of this review, Shane, and indeed, I guess at the initial assessment as well, when you're deciding on pharmacotherapy, obviously, the algorithms now discuss eosinophils. Could you just remind listeners about their role when they're relevant and how to interpret them?
Yeah, the eosinophil piece is relatively new as well. Now, I don't want to overlabor this because it is a smaller part of this, but it is relevant. Essentially, eosinophils are a biomarker that correlates to when inhaled corticosteroids might be of use in patients who have COPD. So when you're, let's say, seeing a patient coming back to you with a history of exacerbations and you're looking at the algorithm for what to do next, you will see within it, based on where their current treatment is, if their eosinophils are quite elevated, we know that can suggest that inhaled corticosteroids can be useful. Now, it's not the only reason we would think about it this way, but it's a useful one for us to consider as GPs because it's easily available on our FBCs and is often there. So there are actual numbers around this that I don't want you to worry about, but there are thresholds above which it might steer you more towards adding in an inhaled corticosteroid. So somebody's already on dual bronchodilators like LABA and LAMA, and you're thinking, okay, if their eosinophils are high and they meet the criteria from the algorithm, it's worth considering adding it in. Versus their eosinophils are at quite a low level, it's very unlikely that will help them. So the correct step at that stage may actually be to look for respiratory review rather than adding in a steroid. So that's the concept behind it. And again, you can get more information on that by looking at the GPU.
Right. We've come a long way now, Shane. We're after getting through our initial assessment. We've gone through our pharmacological and non-pharmacological management options. We've gone through our review of the patient. And of course, really importantly, we need to think about acute exacerbations, which is the fourth and final link on the front page of the General Practice Update. And that'll bring us to page 11 of the guideline.
Yeah, so I suppose the piece I wanted to make here clear is just what is the evidence-based treatment for best practice of an exacerbation. So depending at the time you would have qualified through medicine, there might have been different things done. We might have memories of working in the hospitals or in the EDs or that. So when you see somebody coming in with an exacerbation of their COPD, there are certain treatments worth considering. I might just preface this by saying that all patients with COPD should always be prescribed a short-acting beta agonist. And the reason for that is when they get an exacerbation at home, that's the first line of treatment for them. So if they're feeling a flare-up of their symptoms, shortness of breath or increasing cough, that's the first thing to do for them. So patients with COPD will be one of the cohorts with inhalers that will regularly have salbutamol prescribed, because that's no longer the case in other areas of medicine particularly. But within COPD, that is something a patient should always have. So regular salbutamol on their prescription. But let's say the patient is coming in to see you now. They've contacted the surgery saying they're feeling unwell and they're coughing and that. And people will ask, well, what is the dose of steroids I should consider here? And the answer is clear cut from the guidelines. It's delta-cortical, 40 milligrams once daily for 5 days. Okay, so it doesn't need longer than that. It doesn't need a reducing course over time, which would have been something that we would have done in the past. 40 milligrams once daily for 5 days. In terms of antibiotics, the correct thing to do there is really look at antibioticprescribing.ie. We're talking about first-line antibiotics. Typically, you'll be looking at amoxicillin, 500 milligrams 3 times daily for 5 days. So a 5-day course is typically appropriate, as opposed to anything longer. It doesn't typically need broad-spectrum antibiotics unless you have an unusual case disease, which will often be flagged by respiratory. So for the vast majority of people, you will be managing with straightforward antibiotics for 5 days, antibiotic prescribing.ie, and delta cortical 40 milligrams for 5 days.
Okay, that's really clear. Sometimes when patients come back from respiratory outpatients, you'll see them on, prolonged courses of things like azithromycin. Is that something that should be specialty led?
Yeah, I think the guidance on this is pretty clear. The azithromycin piece is definitely part of the armory for treatment of COPD, but is unlicensed actually, and should be commenced by a respiratory specialist. So I think the respiratory specialist could be at the hub or in respiratory outpatients, but that's where that should be coming from. And there should be a clear plan around that. It's worth noting, by the way, that the evidence base has never shown use for chronic azithromycin beyond 1 year of treatment. So I think this is where the respiratory specialists come in, and another great use of the hubs, because that's where there should be a consultant that we can refer patients to.
Okay. So we've been through the body of what we can offer our patients in terms of non-pharmacological and pharmacological options in an ongoing basis, and also during exacerbations. But of course, it's really important to keep our patients at the centre here and to continue to offer opportunities for them to empower their own management strategies. And you end the general practice update quite nicely with a signpost to the self-management plan.
Yeah, the self-management plan is ideal for patients to have, not unlike patients who have asthma, where we give them an action plan. We do in an ideal world at the CDM reviews, we would consider giving a self-management plan to patients, so as they're armed when they're at home with, what do I do in the first stages when I feel unwell? When do I need to see a doctor? And that it's available on the GPU, it's available from the HSE as well, and is a good thing to do.
Okay, so on that point, Shane, and maybe we might wrap up on this, it's interesting, I suppose, just to take a step back and reflect on how much has changed in chronic disease management more broadly, not just COPD management. And your general practice update reflects that really nicely. But also our conversation this morning, you mentioned things like, quicker access to respiratory consultants and to investigations through the respiratory hubs, as well as the improved outcomes from things like the chronic disease management programme. Could you maybe give me a few comments on how all that's been going and some of maybe the outcomes and what's coming next?
Yeah, I think the whole advent of the chronic disease management programme and the integrated care hubs coming in evolution has been really a sea change in general practice. In my career to date, it's been one of the most fundamental shifts, and all elements of the health service were involved in this. So the HSE itself, the Irish College of GPs, the IMO in negotiating to get these contracts up, were all highly effective. So we know the chronic disease management program, and I know GPs listening to this will be very familiar with it, but it's worth reflecting this started at the beginning of COVID in March 2020. You couldn't have probably picked a worse time to start something, but it's been incredibly well taken up. We now know that 97% of GPs around the country are providing the chronic disease management contract to their patients, and the patient sign up to it has been extraordinary. There are huge numbers of patients around the country enrolled in the CDM program now. And when we talk about the CDM program and also the hubs, they really are, as I referenced earlier, manifestations of Sláinte care. And from the HSE perspective, they use the term enhanced community care. So they're looking to do things like, they will call it shifting left. So moving the care of patients closer to the community, out of the hospitals where traditionally patients with COPD and the other conditions within the CDM program would have been managed. So those patients would have been attending outpatients, perhaps long waits to get to the outpatients, seeing different doctors for each one of the conditions that potentially they had. So if they had ischemic heart disease or COPD or type 2 diabetes, that could have been 3 different outpatient visits. Whereas, as we know, the CDM program is a multi-morbid model. So we see patients in our surgery with all of those conditions, which is right, because we see the patient as the patient and we try and optimize all of those conditions. So it's a much more effective way of approaching things. We're arming GPs with the knowledge they need to be able to manage the conditions, or at least that's what the lead's role would be. My role within adult respiratory and the other lead roles within the college. And we're also arming GPs with direct access to the investigations and the expert advice they need to make decisions. So we referenced spirometry earlier, access at the hubs. We referenced access to other tools at that level. So that's very useful. And also, if we run into a problem and we've done everything we can, we should be able to get expert advice there. So where do the hubs fit in? I suppose at the very basic level, if we want to get access, as we said, to diagnostics like spirometry in the respiratory area, that's perfect. If we want to get respiratory nurse help, perhaps around inhaler technique or education, that's extremely useful. If we want to get pulmonary rehabilitation with the physiotherapists there and the nurses, that's really useful. If we're running into problems around what to do next, or a case isn't making sense to us, or we've done everything we can do based on the guidelines and the patient still has symptoms, we can refer to a consultant there. And all of those services are built to support general practice and ultimately support the patient. From the Department of Health perspective, with a growing population and lots of people having problems, the earlier we intervene, the closer to the patient in the community, the less hopefully exacerbations and hospital visits and hospital admissions we will see, which benefits everybody. The individual as the patient, who's much happier, obviously, to attend their GP than to be trucking in and out to the hospital for multiple visits, but also reducing the visits to the EDs and the trolley counts. And there's certainly, it would appear that there's been some improvement in that area over the last couple of years. And certainly it is probably not coincidence that has been the success of the CDM program and the advent of the hubs during that time. Really, from a patient perspective, the CDM program is excellent. From a GP perspective, it's very popular, and I think most GPs would find it to be a really useful addition to their practice. And then from a HSE and Department of Health aspect, it's also been hugely successful. So generally a really good news story, which is not something we can always say in healthcare, but in this one, it's a really positive story.
Many thanks to Dr. Shane McKeogh for speaking to me today. And don't forget to check the show notes for chapter markers and links to useful resources. And if you've any comments or feedback on today's show, or indeed suggestions for future episodes, please let us know. You can contact us at podcast@icgp.ie. And that's it for today's show. Many thanks again for listening, and until next time, take care.